Right. I apologize for my camera. I've been using it all morning, and maybe it's tired of seeing me. I don't know. But anyway, thank you for joining us. So this talk is about combining artificial intelligence with locomotion analysis and balance training, as Rana said. So I'm the director of education for DigitSoul. I'm also in private practice. So I've been practicing for about 25 years now, and I've been, using locomotion analysis in various aspects. I was in full-time education and taught biomechanics and conditioning and performance-based outcome measures, which is my academic graduate work. And then I'm also a doctor of chiropractic. So I use it in clinical practice for treating patients as well as evaluating athletes from a performance perspective. And so the idea of this talk was to sort of combine, how do we use a performance-based outcome measure system, specifically locomotion, and a really basic premise with balance training. And the reason I had chosen this topic because it's something I think it's really simple to implement at low cost, at least the balance aspect of things, but to sort of overlay that connection to the locomotion analysis component. And that's basically the description. So I saw some names I've seen before. So there are some people that have listened to me speak in the past. And so you probably already know I use human performance analysis, like I said, as my intake for a variety of patients and people that I work with, because it provides a lot of information for us. We'll cover some of that. And then, here I wanted to take just one bit of that and make a comparison and at least either, as we say, plant a seed, because you plant a seed and then, the plant grows. This is more of a, plant an idea and then, maybe it'll be something that you might be able to utilize. So a couple of key points include just really locomotion assessment, and then the simple components of a static training program. And what I think you might find interesting about this is we also use it as an empowerment builder to improve compliance with patients, because it is very simple and it's something that they can do on their own. And then we can add a motivation component to it, which I'll talk about in a little bit. And if you've heard me speak recently in the past, then you'll know that this is my quote that I've been using a lot lately from Jordan Peterson. That is one of the things I've learned is the best way to learn about something is to talk about it. When I'm lecturing, I'm thinking, because there's lots of things for sure I don't know to be the case. And so I always like to present a little tidbit, because the topic can be extremely broad and there's a lot of information to that. So I don't want you to think that this is everything. So we're going to look at a slight historical perspective. I usually talk about that in many of my presentations, because it gives us some indication as to how long we've been talking about things. But I'm going to do that more through the key points defined and some definitions. And actually, in this talk, I spent a bit more time on definitions than normal, just, to really make that solid foundation of what it is that we're having this discussion about, and to look at, its level of complexity and how we bring it down into really something as simple as this balance trainings. And then we'll get into balance training and just sort of my conclusion. So I want to provide just an operational definition section, probably things that you're very familiar with, but just to make sure that we're kind of on the same page, so we're understanding what these terms are consistently between all of us. So sensory input really comes from receptors, so things that are going to measure information from internally and externally outside the body to feed into especially our neurological system. So then we can make a decision what to do about that information. And related to that is a motor response. So motor response can be a reaction or reflex, and I'll define those in a moment as well. And so the motor response is basically the musculoskeletal system making a decision as to what we're going to do about that information, right? So if you touch a hot object, your body probably wants to pull that hand away from that. And so that's sort of that motor response. And that's something that's typically going to be involuntary, so I didn't have to think about it. And that's kind of this difference between a reflex and a reaction. And they're basically different order levels in the nervous system. And so a reflex is something that didn't require integration with the central nervous system. So it did not have to go up and synapse in the cortex, right? Because that, even though it moves relatively fast, you wouldn't want to take too much time if you were touching that hot stove to pull it back and not burn yourself, at least minimize the amount of damage. And also those things are ingrained inside of us. And so those are things that we don't really train. They're part of our growth and development and the innate process of who we are as a species. And so a reflex takes a really, really short period of time. So it can actually take, a visual and audible stimuli can cause a reflex reaction, again, like touching a hot stove or seeing something of life and death situation in front of you. And, even as short as 13 milliseconds. Sometimes there's a little bit of a delayed response depending on how fast or excuse me, the distance at which it needs to travel. So I use the example of a deep tendon reflex. So it takes a little bit longer just because we have to go from the tendon, the patella tendon, make its way to the spinal cord to then react and make its way back to the quadriceps to create that knee-jerk reaction. But the visual audible stimuli can take place even more rapidly. And I use the picture down here of a sprinter because in sprinting, we use that concept to identify whether or not someone faults, right? If someone can jump into, even though they didn't fault before the firing gun goes off, that if it was in less than what's considered to be a normal reflex time, that someone can respond to a stimuli, and that crosses over into the reaction as well. How quickly that happens could indicate that they weren't actually reacting to a stimuli, but yet trying to predict when it was going to happen. And so a reaction is a little bit different in that we have that stimuli come into the body, it makes its way up to the cortex, up to your brain, and you process that information and you make a decision. And in the case of a sprint start, you're making a decision to leave the blocks and basically start running or sprinting down the track. And so a reaction is a little bit different in that it does require more of this voluntary movement pattern, right? So it is something that we can actually train and we can make changes to. So they're not the same, although we do have some interesting what might look like an overlap, but we do look at them differently. Agility, a rapid whole body movement with a change in velocity or direction in response to a stimuli. So this is where we start getting into, how the body as a whole is going to respond to some sort of information, right? And so I like using this. It looks like it's complicated. Well, it's because it kind of is, because agility, and I use this hierarchy in invasion sports. Although I think really any type of situation that requires, rapid changes in body position falls in that similar premise. But the three main components of it, from cognition or, brain activity, to the physicality, right? So what capabilities do you have? How fast are you? How strong are you? And then the technical aspect, how good are you at a specific change in direction or movement pattern? And then, as I said, that, anything that could require a whole lot of change in direction. So walking in traffic in a busy street, well, you don't consider that really an invasion sport, but it's maybe an activity of daily living. that does require, a certain degree of agility. Or, if you live here where I live in New Hampshire in the United States, we get snow and ice. And so sometimes you may slip, and to keep yourself from falling, or you're in traffic, or an animal comes out and surprises you, that's actually a form of agility as well. One of those subcategories that we looked at was cognition. I spent a fair bit of time evaluating cognition, especially as it integrates with what many of us do in physical medicine and rehabilitation, because it does influence some of the things that we assess. It influences some of the progressions that we see in rehabilitation. In general, it's how we take in information and process it, right? And so there's learning, there's memory, there's perception, there's attention, and then it further, breaks down into some of these other categories. The reason I bring this up too is it gives some indication as to how we can train cognition, right? And it's not just from the thinking process, but as we just described, that a stimulus outside of the body making its way into the body, causing us to think about it and then respond, even a motor response, also helps to develop cognition, which is also why, in the opposite, cognition can influence motor movement patterns. So balance is sort of one of these things. And it brings together a lot of these concepts, from cognition to reaction and reflexes. Why? Because we have some of these ingrained and embedded in us, to where we want to maintain certain positions when we are upright. And the example, again, as we're going to be talking about here in a moment, is going to be locomotion. And so we have certain patterns that are reflexive, certain patterns that are reactive, certain patterns that are highly voluntary, and they include both dynamic and static components. So this balance is the ability to maintain center of mass, right? And that's over a base of support. Stability is a little bit different. So stability is your ability to maintain, right, a sense of center of mass over a base of support, but it doesn't necessarily have to be balanced, right? So it can be off center, and that's fine. And that's actually another important concept and a component to locomotion, is we're constantly disrupting balance, right? Because it's overthrowing balance that projects us and moves us forward in that horizontal fashion, if you're walking or running, for example. So related to this balance, it requires three main components: a somatosensory, a vestibular, and a visual. And we'll look at those a little bit here in a moment. So related to kind of bringing a lot of these neurological components is something called brain speed, or neural integration. And there's a law associated with this, Hicks law. Time it takes to make a choice is linearly related to the entropy of the possible alternatives. So what that means is, when a stimuli enters the body and makes its way up to the cortex, you have to integrate that, and you have to make a decision, right? And you're going to consider the various opportunities or alternatives and the potential outcomes. And that's why, when we look at it from a sports performance perspective, why it's important that we have practice and play help to further facilitate improvements in human performance, because it's giving you more alternatives and more definition as to some of these outcomes. Now, that's changed a little bit, because we know that it's not purely linear. It's quite curvilinear, in fact, that there's so many different, or almost an infinite number of combinations that we could come across, and that sensory input is also going to be very highly detailed as to how we may respond, right? So if we think about some of the patients that we treat, as we start to see sensory deficits in these patients, they start to respond differently, right? And so this concept of brain speed could be one of those barriers to making that decision and making that appropriate decision. And it's not just the outcome itself, but it's also in the duration, right? The length of time that it takes. So if you look at this picture, right, you really have two options. Some of you are looking at and seeing a bunny rabbit, and others of you are looking at it and seeing a duck, right? So this concept of brain speed it really became especially popular back in the 1970s, and it was through what was referred to as the useful field of view, right? And so that's sort of your peripheral vision. But it's not just your peripheral vision in anything you could possibly see. It's your peripheral vision in your ability to be able to take in that amount of information and conceptualize it, to actually decipher that information. So as we are younger and throughout growth and development, it's a little bit narrow, but as we grow and we develop, it becomes more broad. And that's, again, if you're dealing with an athletic population, we really want to enhance that. And that's why we put them into as many different situations as possible, and why it's probably benefit to have an athlete play multiple athletic events instead of focusing on one specific, because there's going to be some of that overlap. And then in the older adults, as we start to get older, we tend to lose some of that useful field of view. So it narrows, and that also makes it more challenging to integrate or take that information. And because brain speed processing, and when it comes to reaction, when it comes to agility, right? Remember that cognition is one of those components, and that can increase the cognitive stress or the cognitive load and make it more challenging, which is why that brain speed processing concept is not purely linear. It's again, it's very quite linear. So there's been many programs that have been used to develop useful field of view training in the older adult population to actually reinvigorate, improve their ability to drive automobiles. And that's where this actually began. Was, there's a cliche, right? So something that we all say, that older people don't drive as well. There's actually some truth to it, and we have a scientific explanation, and that's what useful field of view is. And we found out that through training we can actually regain that, we can get some of that back. And that's why we also know with younger persons, right, during growth and development, or if you work with sports performance and youth athletes, that's why this concept of an athletic development program is very popular these days, because we can have a lot of influence. And then this basic definition: artificial intelligence in healthcare, right? Because that's one of the concepts in what I'm using to look at this assessment piece. And so it's taking basically a computer-based or microprocessor system, and it's collecting very similar data that we would as humans, although it's more easy to integrate a lot of technical data, especially from systems like camera systems and force platforms and other external sensors outside of the human body, that in our case, that we use to evaluate human movement. And what it does for us is it allows to sort of remove some of maybe the negative aspects of being human, and be much more detailed in its evaluation process, but also be more detailed in the thought process and the information that it will provide as it integrates all of the information from these different sensors. And so we're seeing this artificial intelligence in healthcare, right, grow dramatically. And in one of these areas is in movement analysis. So movement analysis, we look at obviously how the body moves. We can break it down into relative specific positions in the movement of an articulation, right? How the knee joint moves. We can also look at the knee joint relative to another joint as it moves. We can also look at it relative to other external components, such as ground reaction forces. So one of those things that we utilize is going to be gait as part of a locomotion analysis. Why? Well, that's why I spent that time, sort of laying that definitional groundwork in terms of cognition, in terms of reflex and reaction, neurological components associated with that. Is that locomotion, moving from point A to point B, right? So I want to move from this room to that room, or I want to walk down the street or cross the street, whatever the case may be, that typically involves some form of gait, right? If you are bipedal, if you can actually walk or run, and we can evaluate that. And the reason why that's a really good opportunity is it brings together a whole lot of different systems and a lot of activity that we can look at as a whole, but we can also break that down, right? So we typically break down this into a stance phase and a swing phase, and then we can further categorize some of those components and see what they mean to us in terms of locomotion analysis, which is something we're going to do here in a moment. So I emphasize and highlight this neuromuscular component, reflexive patterns, as well as a lot of voluntary motor control strategies. Some of them are on the conscious level, some of them might be on the subconscious level. Some of them are gross patterns that might be easily identifiable. But then when we start to see changes in them, they're not going to be quite as easily identifiable. And that's the reason for utilizing some form of technology here. And again, adding the AI-based component to it, the artificial intelligence, also helps us to take a lot of this information that some of us may have used in a lab and had to integrate it, on our own and figure out what exactly was going on. So in the movement analysis, the basic component of the stance phase and the swing phase, we know that on average we spend about 60% of time in the stance phase and about 40% of time in the swing phase. So as you can see, we can take that stance phase and we can break it down into contact, load response, mid stance, terminal stance, and pre-swing. Right. So those are all things that happen during that stance phase. And some of those things can give us a little bit different information. We can look at trajectories. We can look at the stability. We can look at time markers. We can compare the right side to the left side, right? Because in general, we're supposed to be fairly symmetrical. We're not 100% complete symmetrical. And there's a reason for that. And we'll talk about that in a moment. And then even during the swing phase, so even though the foot is not in contact with the ground, we do have certain parameters that we can evaluate to give us some information as to the quality of that swing phase and maybe what might be going wrong or even what might be going right. And again, something very simple is to look at the comparison between that right and the left side, right? So gait, obviously, it's not a postural evaluation, right? It's not taking statics and breaking down into various components, and we're suggesting that we can do that, even though I'm going to go down that path, okay? And so I am going to take part of gait, and I'm going to make it static, and I'm going to take some of that information, and we're going to use that as part of our rehabilitative process. And I'll go through and I'll tell you why that's going to be important. But so it can still be helpful in not only giving us some of that evaluation process, but also in the rehabilitation process. And I think what's interesting to me, especially about locomotion, is it's a tool. So we use it to evaluate the quality of something, right? Could be their quality of movement. It could be the changes as a result of an injury. But even at a higher level, a more global level, it gives us some quality as to, some of that health. So we're gonna break that down even more, and we're gonna look at some specific components. But if we think about this concept of the stance phase, for example, that we know that walking we go through, and if we could stop in a moment of time, we do see that it's a series of single leg balances, right? So there are times when we have 2 feet in contact with the ground, and if we're walking, and there are times that we have 1 foot in contact with the ground, and we have to create strategies for our ability to maintain that position. And we can use that for an assessment component as well as some of the training component, right? And so if we look at that individual side, then one side can go wrong, and we'd be able to identify some of that. And what would happen? Well, we might see some increases in double support. We might see some increases in contact time. We might see some changes, usually decreases in step length and stride. And again, if someone's taking a really short step, you might be able to see that. But there's other quantitative components to this, and it's actually the quality of those steps and strides and contact time that is also of interest, and something that we can use to our advantage, right? But in any event, balance is a very critical component, with regards to especially walking, right? We joke when we say that, you don't actually have to learn how to walk before you learn how to run. And we only say that because they're very different locomotion patterns. The reality is that we typically do learn how to walk before we learn how to run, because that's the typical, growth and development pattern, which is important because we're building, from that walking component, some of the characteristics that will then carry over into more advanced movement patterns. And and if you've heard my last talk, I talked about my daughter and, having deficits, not in fine motor movement, but actually in gross motor movement patterns, which I think is interesting, especially during those earlier stages. And you would think that it really should be the opposite, but it's not. So the basics, and this is where the AI comes in, and so this is where I can look at a dashboard and say, okay, so it's telling me immediately that symmetry is within the normal range. It tells me that speed was in the normal range, and that cadence is within the normal range. So the symmetry characteristic is actually contact phase. It's looking at the contact phase between the right and the left. So it's a real high level global look at, okay, so it's not telling me the quality of the contact, but at least it's initially telling me that they are symmetrical. So if there's not good quality, it's probably poor quality on both sides. The speed, and I say this a lot, and a lot of people, maybe think it's a waste of time or consideration, but if you do an appropriate, movement analysis in locomotion, especially for gait, the average speed that someone walks it's about 5 kilometers an hour, 3.0 miles per hour. And why is that important? Well, that's a really interesting metric that says they're capable of moving at what's considered to be the average. And then you'd have to think, well, if they're not, what is going on? And again, it's not specific, but it at least tells us that, first off, maybe they don't feel safe, right? And maybe they're taking really short steps, and it's difficult for them to move that fast when they have really, really shortened stride patterns. The other benefit from understanding, whether or not they're moving that fast is that's also a characteristic of aerobic capacity, right? So functional capacity, which, could be indicative of them being sedentary, a cardiovascular condition, which then is linked to things like diabetes. Is there an obesity consideration? And you can start to build, some of that information with your intake and your history and some of the demographics of your patient. And then again, something really simple is looking at cadence. So the system automatically does the computation to determine whether or not the number of steps is appropriate with the speed that they're running at. So here's a pathological analysis. And so, for example, this particular person was given the same criteria to walk, and it shows that they were symmetrical. So again, it doesn't tell me the quality of their contact phase. It just tells me that they're the same from right to left. But when this patient was told to walk with intent as fast as they can, under comfort, as though they wanted to get someplace, they're only capable of walking at slightly less than 1 mile per hour, which is about a third slow. So the system automatically tells me that it's in the red. And again, I still look at the number because I want to identify with the number. And then it also tells me relative to their speed, their cadence is also slow. And then we look down at their walking profile here. We see that they're spending 70% of the time in the stance phase. You'll also notice that, you can see my cursor here, you'll also notice, and I'm circling the 21%, they're spending more time in double support phase, right? And if you remember back to a couple slides ago, I had mentioned that that's one of the things that we tend to see when there is, some inappropriate gait patterns, right? So they're spending more time in the stance phase, and obviously they're spending more time in double support phase. So even now, it's not telling me exactly the quality of these things, but at least it's indicating and it's saying that there's something wrong. Sometimes I'll be able to identify that with some of the history or other physical examination, or, if you have a system that can go in a little bit deeper. So it shows us that the duration of the strides is actually really, really long. And what does that mean? Well, that is also, remember, relative to the other metrics that are being calculated or that are being used to compute the stride length is the duration that it takes. So even though she's walking in a very short stride pattern, it's taking her a considerable amount of time to accomplish that, right? And then the stride length we can see is extremely short, even for a person of this height. So it takes into account the demographics of this patient and does that computation for me. So I know that, because if this person, was only 1.2 meters tall, then it automatically calculates to let me know whether or not that stride is appropriate for someone of that particular stature. And again, it also gives me the swing time and then the stance time. And the stance time is something I look at a lot. So we already know that not only were they moving really slow, but they are also spending a lot of time in that stance phase, not only based on the percentage, but also the overall amount of time relative to their walking speed. The other information that I can get is looking at their trajectory of their walking pattern. So when we see people that walk that slow, it means that, again, their functional capacity is low. And if you identify that this patient also might be sedentary, could be obese, either diabetic or pre-diabetic, then you need to start to think about, well, what does their neuropathy pattern look like in the lower extremity? And we tend to see people start to move into a more pronated walking pattern as a result of that. And we're able to see some of that here. So we see that this particular person does not like to heel strike or does not spend a lot of time in that heel strike pattern, and they spend a great deal of time in that foot flat position. Why? Because you have more in contact with the ground, and that goes back to another concept in the definitions we talked about, which is stability and balance, right? They feel more comfortable in that foot flat position because they're going to be more stable. This is also something that provides us that information that says, they have pretty good clearance, but you can see on that heel strike angle, so this is their foot relative to the ground, they take steps relatively flat. And that actually makes sense, because if you watch someone walk with really short steps or stride lengths, they do tend to step in a flat foot position instead of heel striking like most of us. And again, that goes into a more detailed evaluation of what gait really is, right? Because remember that part of normal gait, especially walking at that average speed of 5.0 kilometers an hour, we know that we're constantly disrupting that balance component. We're still stable, but we're disrupting that balance because that's actually what helps to project us forward and move forward. And then also in the foot progression angle. So it shows me that she really does externally rotate, especially on that right side. So she has a compensatory mechanism to that. And we can identify with that patient. And yes, she has a history of falls, many severe falls. And so that's one of the reasons that, people are concerned and they don't want to fall over. And so they tend to shorten their strides. They widen in the frontal plane. Their gait pattern, they tend to take these more fenestrated flat foot positions. So that way they feel more stable because they have more of their foot in contact with the ground. So this is a running analysis. No, not of the same person. This is a different person. So we can see over here on the left that, again, we look at the symmetry statistic, and we're within the normal values. That's why it shows up in green. We can see their angle strike, and we can also see their loading force when they come in heel contact with the ground. So we've got good symmetry here, and this is at a specific speed at 6.8 miles per hour. And we see that their stride lengths are going to also show up and be relatively equal. Very consistent in their flight phase, and we see that repeatedly over and over and over again. So really a normal walking pattern here. Same person, same pattern, same shoes, same everything. We increase their velocity, their running speed, by approximately 9%. And that's consistent with the literature showing that, parameters should change. Therefore, I should see a longer stride. And that makes sense. We moved from 81 to 89 inches. But we start to see some problems here, and we start to see a degree of asymmetry, right? So we're seeing more contact time being spent on that right foot. And so why does this matter? Well, if this was an athletic person and they wanted to improve their speed, or they came to me because they weren't running efficiently when they were moving faster, and it also would potentially predispose them to injury. So a couple things we see when we see these asymmetries in certain movement patterns is we see a limitation in improving in their performance, and then of course there's an increase in their risk. So this is their trajectory in contact time. So this is at heel strike. They have an inversion angle at heel strike of approximately 15 degrees. It's a negative 15 degrees because it's going to be inversion. And we can see that their pattern is a little bit different from the left and the right. It's consistent, even though that they start running faster, but here's another statistic to evaluate. These black lines on either side are the standard deviations, right? So the dark line is your mean or your average in this particular metric. So one of the things that we start to see as this person starts to run faster is we see an increase in the standard deviation. More so on that left, but also a little bit on the right. I don't know if you can see that too well in the picture, but and so that's something else that we look at. And I can't pick that up just by watching someone, but that's something to take into consideration. Why would we see that? Well, it's potentially identifying some weakness, right, in their turnover rate as they go through that stance phase. Maybe they need to work on some strategies for absorbing that energy and then turning over that energy so they get back into the air as quickly as possible. Or they have some stability issues, right? And we're seeing some deviation in that frontal plane, and that would be a reason to take that into consideration, right? And that's what kind of leads us into this balance, right? So the balance component is such that, you know, it's part of being not necessarily stable, right? Because we constantly go into a stable and an unstable position, but we essentially have to get some degree of balance, right? And there's always a point in contact that if we could freeze frame, you know, any point in contact when we are in foot flat position, because that's your base, right? If you don't land on a good base, it's going to be very challenging to correct that and then move to the ability to then take off from that base. So if we improve balance, at least maximize balance, then we should be able to improve the overall performance. And that's again, to look at what are the three components: the vision, vestibular, somatosensory, or proprioception. So the proprioception is kind of, you know, the area that we're really focusing on here, and we're gonna, like I said, break that down into that stance phase and look at this single leg balance component. And there's a relationship here. And that's where, you know, we use evidence-based practice to say, okay, just because we are on one foot when we're walking or running, if we train that, does it really matter? Well, the evidence says that, yeah, it does. And so my point is that there's a relationship between that single leg balance and other performance factors, which is actually looking at gait patterns, which is actually looking at single leg performance in vertical jump, for example. So we do know that we do have that relationship. And to be able to break that down, if we think about it from a neurological standpoint, it's that balance component that especially is going to provide some training in that integrative neurological component to it, right? So several studies, and I said I wasn't going to spend a lot of, I still put a bunch of stuff in here, but several studies that do show that, you know, balance, even a static balance, is directly related to components with gait and locomotion and movement capabilities, and then indirectly related to that because of its influence on the brain and cognition. And so that's one of the reasons that, you know, it can be challenging to be able to evaluate some of these without some of the technology, and to be able to assess that level of detail, but to know that, you know, it either has a direct or an indirect, and it's worthy of making that connection And here's what I think is one of the best parts is we have some ability to assess it directly, but that assessment can also be our tool, right? It's our tool in what we're going to do to our patients to make that component actually better, right? So we analyze locomotion to break it down to identify, okay, maybe I need to take a little bit further evaluation into their balance, because the information that's being presented is showing that, yep, there's probably a balance deficit here. So we're going to use that to then further evaluate their balance, and we're actually going to test their balance, right? Other things to consider, if it is related to metabolic disorders, and specifically I call out diabetic neuropathies, right? Because remember that that's your proprioceptive mechanism, that's feeding back into and creating those strategies so your brain can make a decision to make changes and to actually improve your balance and so on. And that's why it's important. And there was a study, I show you the quote here in a moment, that shows that, poor balance actually does influence rehabilitation in general, right? So we use this thing called a slant board. Why? It's really simple. It doesn't cost a lot of money. And even patients can do this at home. So what we're attempting to do is we're attempting to mimic the relative positions that we can identify in that stance phase. And so we can move into dorsiflexion, supination, pronation, or inversion, eversion, and plantar flexion. Okay. Each position has something to do with the contact phase through the cycle. And even though that they're not equitable, they're not equal in that stance phase, we're going to train them very similarly just because it makes it easier. And if you spend a little bit more time on something, it certainly isn't going to be a bad thing. Okay. And so real simple, not only test, but this is actually what we have patients do. So we have the patient put one foot in one of those positions on the slant board. They keep their arms up, or they can keep them by their side, especially if they have a shoulder condition. They can put their arms up at a later date because that actually increases a challenge. And I'll show you another way to increase the challenge as well. And then we have them bring their opposing leg up into 90 degrees of hip flexion. And then the knee is usually going to flex at 90 degrees if they're going to just relax that. So the idea is that they hold this position. We're attempting to reach 30 seconds in each position. And I'll explain a little bit more about that in a moment here. So they step up onto that. So it is dynamic, and then they hold it for 30 seconds. Okay. And then they step back off, and then they're going to step with the opposite foot, and then we're going to turn them around. And then we're going to step into inversion with one foot. We're going to step with eversion on the opposite foot. And then we're going to turn them around. They're going to be on eversion on one foot, and they're going to be an inversion on the opposite foot. You can turn the patient around, and it might make it a little bit easier, but we're looking for 30 seconds in each position here on each foot, right? And the idea is to have an influence. And there's a reason for the 15 to 20 degrees I won't really get into, but many of you probably already know that. And so this is to create a stimulation, right? Because it's a dynamic where they actually step up, but then they have to hold it. So there's a strength and endurance component factor to this for a lot of those people. And then we can take that to the next level. I don't have a lot of time to spend on cognition here, and hopefully you can see the video, but so we have the person standing on a slant board, and once they can achieve their 30 seconds, we now actually add a cognitive load. Right? I have a fancy piece of equipment here that, I can manipulate and make changes to that. It could be having them read. It could be having them turn their head from one side to the other, but increasing that cognitive load so they actually have to think about that. So this whole thing, I have to give credit to my colleague, Dr. Peter Gorman. So we came up with this 2-minute club, right? Why? Like I said, this is very low cost. It's really simple. But in the clinic, we're sometimes looking for motivation and compliance, right? So when they can do 30 seconds in each one of those positions, right, that's 2 minutes. When they can achieve that, they get a t-shirt. And so they then become part of the 2-minute club. It's highly motivating, for both young people and old people. Who doesn't want a t-shirt? I just ran a 5K road race not because I'm a runner, but because I wanted the t-shirt that says I ran the 5K road race. So it's an interesting opportunity, for clinicians to create, a little bit of a community in the clinic. So we have patients do this in the clinic. I also encourage patients to, get a slant board. They're not very expensive, and they can work at this at home. And that's part of the empowerment process, right? And so that makes it real easy to make that transition to where they're not just being tied to the clinic, and actually do this at home, right? So I always reassess them. We do a reevaluation, because that's the performance outcome. We see the changes and we see the increase. They can hold it for 30 seconds. Did it make a difference? And we will say that pretty much most all of the time, if they had a parameter problem in their gait pattern, it actually does have an influence in their gait pattern when we do that post. And that's another thing that we show patients to really make it of interest to them, to make that connection in what it is that they need to be accomplishing. All right. Let me bring us back to the screen. Okay, Rana, do we have any questions?
Hello, Dr. Chris, and hello, everybody. So far, I don't see any questions. I see some thumbs up and some people thanking us. It seems they have enjoyed it, but so far, I don't see any questions. So, any questions for Chris?
That either means I did a really good job or a bad job.
Apparently, I see some thumbs up, so
Okay.
it's a good job. We have Philip typing something, so let's see if it's a question. For the others, you could ask questions in the chat or in the questions tab. You could find those tabs at the bottom right side of your screen, bottom right corner. Oh, so it's just a thank you, and Philip says very insightful.
Thank you. Yeah, I spend a lot of time showing research, and sometimes it's challenging to do stuff. I'm sure many of you do something like this, and maybe it was just reinforcing, its benefit and its ease of use. And I know that sometimes we want to get really complicated, but when we empower our patients to take their own health in their hands, it's a pretty powerful tool, and we need to make that somewhat simple, I guess.
So apparently there's one question. Okay, so we have one question. I'll read it as follows. When doing comparison analysis, is there a progression or regression metric on the report?
So yeah, and it would depend on your system. So I do use the DigitSoul Pro system, and you can click on and do an evolution. So it allows you to either compare two different analyses, or you can compare multiple analyses over the course of time. And the reason that's a good question, because I think it's important that you do that, right? So you do evaluate to make sure. And the other benefit is, when we assess, it tells us that we're on the right track. It means that we're doing the right thing, and that's one way to determine the benefit, as well as getting patients to continue to come see us, especially if it's costing them money, and be really compliant. But yeah, so in my system, I can do comparative analyses between two different analyses, and then I can actually do an evolution, and it shows me their trajectory. And patients love seeing that kind of stuff, because they can connect to what it means when I say, this is you, this is how you ambulate, this is how you walk, and here's you spending time in contact with the ground. And it resonates with them. And we use walking as well. So I do a lot of I do walking on a treadmill, and we'll reinvigorate that. And I say, listen, you're spending too much time in contact with the ground. I want you to focus on, picking that foot up a little bit sooner and making larger steps. And we can actually see that in the system will show us that trajectory.
Thank you, Chris. There's another question. What is the inclination of Slant Board?
So I use 20 degrees, and I know that seems like it could be a little bit high, but the reason I use 20 degrees is to make it easier. So I have one slant board instead of two, because 20 degrees is something that's really important, especially for runners. But the other reason for the 20 degrees is it tends to match up with especially the inversion ankle position. And it's enough, it creates a perturbation, a stimulus to make it more challenging for people than if using a 15 degree. I have colleagues that have multiples, so they may start with a 10, a 15, and then work up to a 20. I found going straight to a 20 has not been a problem. Even in my older adult patients, we do have bars, they can hold on to that.
Okay, and it seems you've answered the last question by Jackie Stewart, because Jackie's asking, why is board angled at 20 degrees? So you've already answered that. Any more questions? So apparently those are the only questions. If you don't have any more questions, then we will thank you for participating in our webinar. I hope you've all enjoyed it. As you have participated in the webinar, and for the ones who watched the replay afterwards, you would be entitled to an attendance certificate, but you would have to email me to request that. So I'm just sending you now on the chat my email. And we would like you to take please 2 minutes to evaluate our webinar by clicking on the link that is coming your way now on the chat. Apparently there's one more question. So do you use gait analysis to assess other conditions like low back pain? Yes, of course, but I'll let Chris handle that question.
Yeah, I mean, so I used to have a lab and had all this equipment. So I actually was seeking out many years ago a way to do that, because I use it for neurodegenerative disorders. I treat a lot of spine. So I use it for low back pain. I use it for obviously lower extremity conditions. It can be used in, so neurodegenerative disorders, we tend to see motor deficit before we see cognitive deficit. And so it's a great way to give some baseline assessment. I use it as a baseline assessment for athletic population. So yes, I do. I use it for, it's part of my intake for all patients. It doesn't, some patients, it may not show a deficit, but sometimes when I see them later on and they did something, we have that basic levels analysis to show them. Most patients that come in with a pathological condition, I've been doing this long enough where I can identify, something.
And if I may add, Chris, that when you're using DigitSoul Pro, you have the option to mention the pathology of the patient. So whenever you mention the pathology of the patient, this would very soon be giving you a comparison of your patient with people having the same pathology. So this is good because more and more, and with more analysis done by people who have DigitSoul Pro, we will be able to see some common traits for patients with diabetics, for example, or people with diabetes, or people with neurological problems, or people with lower back pain and things like that. So Chris can elaborate more, but with this option, it would be very interesting to see the comparison.
Yeah, that's a good point, and I'd referenced that a little bit earlier too. when it came to decision making, for example, that deficits, they're not purely linear, right? We don't just see a little bit of change here and then another little bit of change here. It's especially like in low back pain, for example, that analysis or that influence on locomotion in low back pain is very curvilinear, and so a constant feed of seeing people with conditions, that's referred to as motor learning, and that's where a product or a company takes information and is constantly feeding it. It's almost similar to updating a normative value screen, right? And so, but this feeds into the artificial intelligence component. And so right now, for example, with evaluating low back pain, because there are several studies out there that show that low back pain, for example, does not influence gait, right? And I would argue that because when you look at it, so a Poincare plot analysis, for example, is a complex curvilinear, analysis of the data, and it's very different than just saying, oh, they have a shortened, step or stride, and they have increased contact time. It doesn't exactly work like that, and that's where a motor learning analysis system is going to be pretty amazing, to be able to identify some of those things. And that's why, as you said, Rana, putting in that, and that's what excited me about the program is its ability to accomplish that.
Thank you so much, Chris. And thank you, Theodore, for your question. Theodore is asking if we can send the video of the webinar. In fact, the same link you used to join the event will lead you right after the end of the event. It will lead you straight to the video replay. So you could watch the replay by clicking on the same link. And if there are no more questions, then we will be thanking you all for joining us. Chris, do you still have something to say?
I think I'm good. Just, I want to appreciate your time. This is, as beneficial for me as others, because I love hearing questions that, sometimes I don't think about. But, it's a community that allows us to share information and really just do a better job at taking care of people and hopefully making a little bit of change in the world, right?
So I would just like to add that next week we will be having a webinar on May 19. So please feel free to register for it, and we will look forward to seeing you with us. I will just post the link of the webinar here so you could register for it. The title of the webinar is Digital Gait Analysis to Help Shoe Selection Using AI Based, and I'm just sending you the link for the registration using the AI-based motion analysis. So here's the link for next week's webinar. I'm looking forward to seeing you all. Thank you again for joining us, and have a great evening, everybody. Just 1 second. I see another question by Kus just before we leave. So this is for you, Chris. What is the difference between PodoSmart and DigitSoul Pro? Do you want to take that, or shall I?
You probably know more about it. I mean, I can talk more to the DigitSoul, but there are some similarities, but go for it.
Okay, so basically DigitSoul Pro is an upgraded version of PodoSmart. What is the basic difference is that DigitSoul Pro does not use the Podo station to connect to the insoles. Not all the insoles have batteries and sensors like it is the case in PodoSmart. So basically the insoles are flexible, and they have a small slot, a small pocket where you could insert small pots or small microchips who would do the analysis, and they contain the battery. And then you could move them from one insole size to another size to use it for another patient. And you connect to the insoles using an application on your mobile phone or on a tablet. And then you would be able to see the results of the analyses on your telephone, on your application, or on your tablet. And then you will see the detailed analysis on the interface. What's also very exciting and interesting about DigitSoul Pro, it is more practical to use outdoors because you don't need the Wi-Fi. You can only use the connection on your mobile. The other interesting thing about DigitSoul Pro is that we're constantly developing it. So we will see more and more and more modules related to it. We're going to be adding modules and options. So it is an upgraded version, as I said, and it will continue to be upgraded. So for those of you who are interested to get a demonstration, please contact me. You have my email, you have Chris's email, but please feel free to contact me in order to book you a demo session with the distributor in your countries or directly with us. I don't know if there are any more questions. So apparently no more questions. Thank you so much for joining us. Wishing you all a great evening, and thank you, Chris, for
thank you
conducting this
all.
webinar. Thank you so much. For Podosmart owners, are there any special offers? Yes, please contact us, Theodore. So we would refer you to the distributor in your country, and you would know more about the special offer of upgrading from Podosmart to DigitSoul Pro. Thank you, everybody. Have a great evening and see you soon.
Bye-bye.
Bye.